Gibson. How are you? Hey. No. It's crazy. Busy today. I'm on call. I had stuff all day long. I got to meet with the accountant at 5. Those are always bad. Not a good way to end the day. Not a good way to end the day. Yeah. Oof.
Would you all please rise for our invocation from Dr. Morgan Milford, our chaplain.
Thank you. It says in the Lord's word, "Show me your ways, O Lord, teach me your paths. Lead me in your truth and teach me, for you are the God of my salvation. On you I wait all the day." Lord, grant each one here your insight. Give them wisdom to make wise decisions. Give each one courage to speak from their heart and mind. May the conversations and decisions made today benefit this community, our region, our world. Guide them now to have one heart and mind and purpose. We ask these blessings upon them. Amen.
Now our Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
So I'll call the meeting of the Sarasota County Public Hospital Board meeting to order. I am Bill Noonan. I am the first vice chair of the board, covering for Joe DiVirgilio, who is the chair, who is unavailable today. So, first on the agenda, we need approval of the orders of the day. So I need a motion.
Mr. Chairman, I move approval of the orders of the day.
All right, thank you.
Second.
So we have a motion and a second. Any discussion or comments? Hearing none, all those in favor, please indicate so by saying yes.
Yes.
Any opposed? That motion carries. I need to read a public board public comment. Any citizen desiring to address the hospital board should turn in a speaker card to the board secretary. If the citizen comment pertains to an item on the agenda today, the comment will be heard early in this meeting. Otherwise, it will be heard towards the end. Speakers are asked to limit their comments to 5 minutes. Vendors, suppliers, or other persons seeking hospital contracts awarded on a competitive basis are reminded that their ability to address the board may be restricted by the terms of the invitation for bid, request for proposal, or other purchasing criteria. Lastly, the board has established a claims adjustment review panel comprised of representatives of the board, the medical staff, administration, and legal counsel to review and negotiate the settlement of claims. Accordingly, the board will not entertain comments on or discuss or negotiate claims at this meeting. So next on the agenda is approval of the minutes of the board meeting of February 20th, 2018.
Mr. Chairman, I move approval of the minutes.
All right. So we have a motion and a second. Any comments or questions on the minutes? Hearing none, all those in favor of approval, please indicate so by saying yes.
Yes.
Any opposed? That motion carries. Thank you. Next on the agenda is board reports. I don't believe we have any board reports, so we'll move on. Next on the agenda is modern stroke intervention. Dr. Daniel Case and Dr. Garner, I believe you have
Yes, Mr. Chairman, I have the privilege of introducing Dr. Case. He completed his medical school at Johns Hopkins and went on to do his internship at UC San Diego. He's done a residency in Springfield, Massachusetts at Bay State and completed fellowships at both Harvard and Emory. He's here today to give us an update on modern stroke intervention and the program that we've created at Sarasota Memorial. Dr. Case.
All right. Thanks for having me. So for the presentation, I'm going to talk about kind of the evolution of stroke intervention and why it's important today, because there's been some major changes in stroke intervention which are very significant. So first off, what is stroke intervention? And what we have here is a biplane fluoroscope. So many of you probably remember I asked for money for a biplane fluoroscope, and that's what this is here on that top left. It's critical to neurointerventional, which is a procedure where we use small catheters. As you can see here, a patient lying on the table here. Here's the physician and the technologist. Here's the biplane behind him and computer screen showing catheters being guided from various peripheral arteries, most of the time the femoral artery, up into various parts of the body to perform interventions, in my case, into the brain, head, and neck. And in stroke intervention, we are trying to reopen arteries of the brain that had become blocked in the acute phase within hours. So on this image, we see, just for purposes of this procedure, this is the right carotid artery, the patient's eye here and here. So that's a front view. This is the middle cerebral artery, the anterior cerebral artery. Over here's a side view. That's the same thing. And what happens in this type of stroke is that you have a blood clot that launches into the brain and blocks one of the major arteries. The most common is the middle cerebral artery. And that usually causes a very significant stroke with just debilitating deficits and many times death within months, if not just permanent disability, significant impact on their quality of life. And in the beginning, and we're only talking about the 90s here. In the 90s, we didn't even know if it was a good idea to reopen that artery, whether or not reopening the artery was bad or good, because there are consequences to after having something blocked, having damage to the brain, and then that damage can then result in more damage by reopening it. So it's fairly recent by medicine terms on whether or not we even should open the artery. So 2007, so 20 years ago, they were still studying whether or not we should even open it. So this is very, very new, and they did this meta-analysis that showed definite benefit to opening the artery versus not. Decreased mortality, and this is intracranial hemorrhage, which is one of the consequences of reopening the artery. It's actually low. Whether or not you open it or not, it's about the same. So there's benefit to opening it, not a lot of consequence. So that's in 2007. And what they also learned, so TPA then came out a little bit after that, and TPA is an incredible drug that is able to reopen these arteries very quickly through an IV that they can even give at just even sometimes in the ambulance. We're working towards that. But there's a definite subset of occluded arteries that do not open, even with TPA, and they are called large vessel occlusions. And about 35 to 40% are large vessel occlusions, so a significant number. And those are the internal carotid artery, that's this artery right here, the middle cerebral artery, which is right here, and basilar artery, which is in the back, and I'm not showing it to you. And this right here is a large vessel occlusion of the right middle cerebral artery, and here it is open, which I showed you before. And mortality, look at the mortality. If you don't reopen it, there's significant mortality to not reopening it. So we needed to figure out a way to reopen it, and quickly, because we know time is brain. So there's various different techniques that have been evolving over time, and just to show you how new these things are, this is simply a catheter guided from the femoral artery all the way up to that clot, and then you literally aspirate. And here you can see a little picture showing you that they're aspirating through that catheter, and the catheter is all the way up in the brain up to here where that clot is, and you hope to grab the clot and pull it out. That's been evolving since FDA approval in 2007, and it's getting better and better every year. And what's challenging about this is we're talking about a very small catheter with a relatively large bore relative to the catheter inside, because you want a bigger hole to get the negative pressure through. And so it has to be long, it has to be guidable, it can't damage the artery, and it can't collapse when you suck on it too much. And that's an engineering feat that has taken years to develop, and it's still developing, and it's getting better and better every year. So that's one of the techniques. And another one that's recently come out, but started with this, was FDA approval of the Mercy device in 2008, which is a little corkscrew. And here you can see it on x-ray, that you actually just put into the clot and try to pull it out. It really did not do a good job. It took a long time to get these procedures done, and the success rate was very low. So the next thing to come out was these things called stent retrievers, which are like stents on a stick. And you take these stent retrievers and you bring it up into the artery that's blocked, and this is that left middle cerebral artery. You come up with a little catheter, open up the stent inside the clot, and then pull it out. And here's an example of one done here. There's a left middle cerebral artery occlusion there. The stent goes from here to there. You can see those little dots, so that's the tines, the distal tines of the stent. And then after pulling it out, the clot came out and the artery is open. That was approved in 2012, so that's just not too long ago at all, you know. And then again, very following short order was Trevo, another company, very similar stent, same theory or same way of doing it. Here's another case done here also, left middle cerebral artery. This stent you can actually see pretty well because it's impregnated with platinum, and again, success. And with these new techniques that, as I showed you, are very new, we've started to, in our research of whether or not these techniques work on getting the artery open, we're seeing significant improvements in the numbers, and whether or not we can get research to prove what we're doing. So up until 2015, we had no research, nothing saying that what we were doing was working. The trials that had come out up until that point, 2015, showed no benefit between doing it and not doing it compared to just medical management. And the problem, what we realized, is that number one, the techniques were still evolving very rapidly, but not rapidly enough for those trials. And also patient selection was something that we learned along the way. Patients that don't benefit, we need to know, because if we open that artery up, then we actually cause more harm than good, and it outweighs the actual people we help. So in 2015, once they figured all these things out, they did these trials, and we had six trials come out in rapid succession in New England Journal of Medicine that showed definite benefit to intervention of, I think, a number needed to treat of 1 in 4, that's really good as far as research goes. And that changed everything. Now, these trials were all 0 to 6 hours, so that's how our protocol, we were already doing that protocol at SMH, but it just gave us evidence that we are doing the right thing. Also, some of the trials were actually going out to 12, but there wasn't enough 12 hours from last seen normal. There wasn't enough data to support truly doing that on a large scale. So after 2015, we definitely ramped up. Our numbers went from, I think they tripled here at SMH. And directly following the release of those trials, in 2015, in July, which was right after the last trial that came out, the American Heart Association, Stroke Association, changed their guidelines immediately, saying that we should do this. It is indicated and should be done. So that's just 3 years ago that they finally changed guidelines saying that we should be doing this. Before that, we have hospitals even in this region. You're just lucky if you end up at SMH, because we're the only ones in the region who do this still to this day. And if you ended up before 2015 and you ended up at one of these centers that did not do this, that was it. You got TPA and you crossed your fingers, and that was it. And the thing with TPA is that only up to 3.5 hours. There's a very long list of exclusion criteria. And so whether or not you got the treatment was questionable. If you got it, great. But if it was a large vessel, well, that was just too bad. And because there were no trials proving it, we couldn't tell them, hey, you need to transfer these people to us. You should not be doing this. So when 2015 came and the new guidelines came on, Dr. Concha and myself have been working very hard to work with the EMS, trying to get to the other hospitals and educate them that you need to send these people to us. It's getting better and better every year, but there's a lot of work to be done, because there's still hospitals out there that just don't send them. They just give TPA and sit them in the corner and just hope. I mean, it's terrible. But the thing about stroke intervention, and the reason this talk is short and sweet but fast, is because stroke is changing so fast that it's hard for the community, it's hard for Medicare, for example, to keep up. So Medicare isn't even exactly reimbursing for a lot of these things, let alone saying it's standard of care. So there's still a lot of work to be done, and the research is going so quickly, it kind of creates this kind of ethical dilemma, It's like, how strongly do we do to fight these hospitals to get them to send it to us? Well, so now in 2018, so just a few months ago, 2 more trials came out, large trials in New England Journal of Medicine, Dawn and Diffuse 3. They showed that we can actually help these people up to 24 hours out. That's incredible, 24 hours. So if they last seen were normal was within a 24-hour period, and they fit with certain criteria that they have a large vessel occlusion and they don't have a large stroke already, they have a 1 in 2 chance of getting better if we do this procedure. 1 in 2. They were a number needed to treat of 2. I mean, in medicine, that's almost unheard of. That kind of positive data is incredible. So we're still in this kind of conundrum, too, with this ethical dilemma where there's a lot of people who don't even know about these trials in our community alone. And they still are not even understanding the importance of it. We have EMS, we got with EMS directors before these trials came out. We haven't even been able to get with them yet about these. And we got them to change it to 0 to 12, skip non-comprehensive stroke center hospitals, come straight to us. But we still get a lot of pushback from hospitals in the community that refuse. They don't want to let us do that. They fight to keep those patients going to these hospitals that don't have people like me to do this procedure. And by the way, there's trials that also show that people to go to a center like, let's say, Lakewood Ranch or whatever, doctors, they go there first, then they come to us. Okay, it's great, you're transferring. They do worse than the people who come to us first. That's proven. So we got a lot of work to do as far as this is concerned. We got to get the education out there, let people know that this is serious business. This is life or death, and these people need to come to us. They either need to come to us as quickly as possible, skip those people altogether, or they need to get someone like me, spend the money to get a biplane, train them, and get the service running. And they are years away from that, if not decades. So I think that's my last slide. So the American Heart Association changed their guidelines again, 24 hours. That was just January. So stroke intervention and stroke treatment is changing so fast. It's just incredible and exciting to see. And when you see these patients wake up after an intervention like I do, it changes your world, you know? It really does.
I have a question.
Yeah.
Thank you for the presentation. How many stroke victims or strokes do you see a day or a week at SMH?
For that are candidates?
Right.
So before this trial came out, I'm averaging one a week, average. It should be higher. It definitely should be higher. There's a lot of people in the community that are not getting the treatment they need because they end up somewhere else. Once we get this up and running, because we're still working on the protocol to get the 24 hours, it should double.
To two?
2 per week, average 2 per
Two
week.
per week.
Yeah, probably.
But I got to think in our population of what, 300,000? How many strokes do you think we have a week?
See, that goes back to my other point. There's a lot of people who aren't getting treated. And that number, I don't know.
Yeah.
It's going to be higher. I guarantee it's higher. Like you said, I mean, geez, we are the population to have this need.
Oh, absolutely.
And we need to educate these people. We need to get these people working, and we need to get EMS. We need to get the criteria changed. We need to fight these other hospitals to, hopefully they can just understand the ethical issues here and just care.
Yeah.
But no matter what, things need to change, and fast, you know.
So last question, I don't want to beat this to death, but who makes that decision when the ambulance arrives at the home or the condo or whatever, picks the patient up, and they say, I know you're having a stroke?
Yeah, so
Who makes that decision?
So we set up there's a few different scales that can be used to determine likeliness of a large vessel occlusion in the field. They're very simple, straightforward, only a few different criteria. We educated the EMS on this once we got them to accept this whole idea of skipping. And if this scale, which is only usually 3 or 4 different things on a symptoms scale, if they get a certain number, boom, transfer straight here. Yeah. But right now it's 0 to 12, not 0 to 24. So we're working on that.
Does Manatee?
No, they fly to us, so they're another one. Yeah, they don't have what we do. I developed a very strong relationship with the neurologist there, so they have my cell phone. They call me all the time. But again, the problem, especially Manatee, flight, we always try to get a helicopter, but the helicopter actually takes a long time just to get there, let alone get here. And definitely their outcomes are worse. They tried to get a system like us here at Sarasota Memorial about a year or 2 ago. They tried to recruit someone to do it. They tried to buy the biplane and the equipment, but they just couldn't do it. Money-wise, they couldn't afford it.
How about Pinellas County or Hillsborough? Tampa or St.
Yeah, St. Pete, Tampa, they definitely have multiple centers. Fort Myers, one center. Naples, one. But in our region, from south of St. Pete's and north of Fort Myers, we are it right now. In the future, what we want to see is that multiple centers become required within an hour or a half hour transport time. You have to have a stroke center there, period. That's the way it should be. But like I said, this is moving so fast, we don't even have the regulations in place, let alone the education to do it yet.
What percentage of strokes, occlusive strokes, are large vessel?
About 30% or so.
Okay.
It's a significant number. Yeah.
Thank you.
All right,
Congratulations. Thank you for being here.
So, Mr. Chairman, if I could just take a minute before we move on.
Sure.
Dr. Case, you've been here 4 years? 5?
4.5.
4.5. So before Dr. Case came, we didn't do this. We had somebody here that was sort of part-time doing this from St. Pete. And we were, I will tell you, he doesn't know I'm going to say anything nice about him, but we were able to recruit him in, and he was the only person here doing this. He was on call for 24/7, 365 for 4 years. 4+, right? And we credentialed a couple of months ago, I think it's been a couple months now, a second person to come in and help him. And after we were able to kind of work with Dr. Case to make that happen. And so this is the person that when he would have to go on vacation, if he went to, say, Boston, we'd have to have him on standby with a plane in case he had to get back here real quick. So this guy hasn't had vacation really in 4 years, 4.5 years. So Dan, we all owe you a great gratitude. So thank you. What he also won't tell you is he was an Army Ranger before he got into this. So he's had an interesting career.
Are you infantry?
Yes.
So
Dr. Case's passion is obvious, so.
it is, and we hope we are able to keep up with him, quite honestly. So and like that. So thank you, Dan.
All right,
Okay.
so next on the agenda is the Excel Award. David.
Okay, I am happy to invite up our Excel Award winner for March of 2018, Jacqueline Pettit. Jacqueline, come on up. Again. Come stand by me. Make me look good. All right. So Jacqueline Pettit is our March Excel Award winner. She's an occupational therapist in rehabilitation and has worked at SMH since 1999. Jackie is a happy and positive person with a warm smile. All her coworkers agree. She brings that good energy into every patient's room. She goes the extra mile to make sure her patients are well cared for. She takes extra time to make sure they have everything they need. Jackie is especially knowledgeable about lymphedema patients and has a special way of making them feel comfortable. Her coworkers note that Jackie takes pride in learning new things and sharing that expertise with others. That's one of the reasons they enjoy working with her so much. Another is her willingness to help out whenever needed. Her coworkers conclude that Jackie is a model employee with a genuine human being. Thank you, Jackie, for everything that you do, and we much appreciate it. Mr. Hudson?
Hey, Jackie, congratulations. Is it pronounced Pettit?
Pettit.
Pettit. All right, I want to make sure I got it right. On behalf of the board and the administration of the hospital, it's our privilege to present this Excel Award plaque. Excel recipients are employees who are models of excellence and consistently demonstrate the mission, vision, and values of our organization. They are superior performers that make an extra effort in the quality and care of our patients and families in the community. Hospital board and administrative staff of Sarasota Memorial Healthcare System recognizes Jacqueline Pettit, got it, with the Excel Award for the month of March 2018, signed by David Verinder, our president, and our chairman, who's not here today, Joe DiVirgilio, chair. Congratulations.
Thank you very much.
Perfect. And the microphone is yours.
Thanks again. Tongue-tied now, but I think I'm just thrilled to be working for such a forward-thinking hospital, listening to
Right,
Dr.
pretty
Case.
neat, right?
Yeah,
Yeah.
Dr. Case's information and actually seeing the outcome of the patients that he's treated is spectacular to be part of that. Thank you.
Thank you, Jackie. Appreciate it.
Congratulations, Jackie. So next on the agenda is a report of the medical staff. Dr. Garner.
Yes, the Medical Executive Committee has created several new forms for the delineation of clinical privileges. These include certified registered nurse anesthetist, radiation oncology, the LINCS criteria, pain medicine, psychiatry, and bariatric surgery, and we would request a motion approving these new forms.
Mr. Chairman, I move approval of the following new forms for the delineation of clinical privileges: certified registered nurse anesthetist privilege form, radiation oncology privilege form, LINCS criteria privilege form, pain medicine privilege form, psychiatry privilege form, and bariatric surgery privilege form.
Very good, thank you. We have a motion, do we have a second? All right, we have a motion and a second. Any discussion or comments or questions? Hearing none, all those in favor, please indicate so by saying yes.
Yes.
Any opposed? The motion carries. Thank you.
Thank you. No additional report.
Okay,
Thank
thank
you,
you,
sir.
Doctor. So, next on number 8 on the agenda is the foundation report. Mason Ayers.
Thank you, Mr. Chair. This Friday, we're having our Women in Medicine Educational Luncheon. If you enjoyed Dr. Case's talk today, he is going to be speaking at the luncheon as well as Lori Lang and a couple other physicians. The topic is going to be stroke care. We're expecting a full house at Michael's on East. Also, in May 4th, Friday, we're going to have our annual golf tournament at Laurel Oaks Country Club, and the proceeds from that tournament will go to support SMH staff education needs. That concludes my report, Mr. Chair.
Okay, very good. Thank you. Any questions for Mason? Okay.
Yeah, I do have one question.
Yes.
I was told that the men aren't invited, is that correct?
They are invited. I'm going. Absolutely, you're invited.
Thank you.
Very good. Thank you. Thank you, Mason.
Mhm.
Okay, next on the agenda is the Secretary's report. Tram Hudson.
Mr. Chairman, I would like to call the public's attention and our board members' attention to our calendar in the month of April. On April the 16th at 9 a.m., we will hold our Governance Committee meeting. At 10:30 that morning, we will have the Quality Committee meeting. At noon, we will conduct peer review, which is closed to the public. At 12:30, we will review our financial statements, and at 2 o'clock, we will convene in this room for our board meeting. And that's all I have to report, Mr. Chairman.
Okay, thank you. And next, our Treasurer's report. Sharon Wetzler de Peters. Sharon.
Yes, I propose a motion. I move approval of bad debts and charity care for the month ended February 28th, 2018, in the amount of $19,674,000.
Okay, we have a motion. Is there a second? Second. All right, we have a motion and a second. Any discussion? Hearing none, all those in favor of approval of the motion, please indicate so by saying yes.
Yes.
Any opposed? The motion carries. Thank you. Next on the agenda is financial highlights. Our CFO, Bill Wojin. Bill?
Thank you and good afternoon. I have the highlights for February, and we'll start with operating revenue. So for the system, our operating revenue for the month of February was $74,811,000 compared to a budget of $67,171,000. Fiscal year to date, and this is 5 months of our fiscal year so far, $343,571,000 compared to a budget of $323,365,000. For the system's total expenses for the month of February, $67,173,000 compared to a budget of $64,273,000. And through 5 months of our fiscal year, $327,881,000 compared to a budget of $320,284,000. Our operating rate income in the rating agency format for the system. In February, we had operating income of $10,919,000, which generated an operating margin of 13.8%. This compared very favorably to the budget, which was $6,248,000, which was a budgeted operating margin of 8.7%. Fiscal year to date, our operating income $32,167,000, and our operating margin through 5 months is 8.8%, and the budget was $19,834,000, operating margin budgeted at 5.7% through 5 months. Looking at the hospital statistics, these are all fiscal year-to-date numbers. Average daily occupancy, the actual 527 patients per day compared to a budget of 526. Our average acute length of stay, 4.45 days, and last year it was 4.44 days. Admissions we have so far 15,342, compared to a budget of 14,408. For the hospital's surgery cases, we have 9,852 so far this fiscal year, compared to a budget of 9,590. And births, we have 1,503, compared to a budget of 1,482. The hospital's outpatient registrations so far this fiscal year, 198,630, compared to a budget of 188,580. And emergency care center registrations between the two ERs, Northport and Main campus, 53,389, compared to a budget of 52,906. And so far this fiscal year, our case mix index for all patients stands at 1.85, and for Medicare patients, 1.93. Mr. Chairman, that concludes my report, unless you have any questions.
Any questions for Bill? Okay, thank you. Very good. All right, next we have our committee reports. Finance Committee, James Meister. Jim.
Thank you, Mr. Chairman. The minutes of the January 16, 2018 joint meeting of Finance and Audit Committees were approved. David Verinder, our CEO, and Peter Taylor, Vice President of Strategy and Marketing, gave a presentation on the planning for the proposed hospital campus on our Laurel Road property. The presentation started with David giving an overview of our South County strategy and Peter providing information on the service areas of demographics and market data. Steve Jackson of the Flat Architect Company presented a conceptual site study and design schedule for the proposed hospital campus. The project plan is to have planning, programming, conceptual design worked on during this spring and summer, and having schematic design completed by September of 2018. Inclusive of work already completed, the cost to produce a master plan and schematic level design and pricing documents is not to exceed $8,250,000. This expenditure was budgeted for the year 2018 capital budget. I move approval of the production of the master plan and schematic level design and pricing documents for an expense not to exceed $8,250,000 from the approved year 2018 capital budget to further define the Laurel Road Hospital campus as recommended by the Finance Committee.
Okay, we have a motion. Is there a second?
Second.
All right, thank you. We have a motion and a second. Any discussion or questions for Jim? All right, hearing none. All those in favor, please indicate so by saying yes.
Yes.
Any opposed? That motion carries. Thank you.
Thank you, Mr. Chairman. Bill Volgen, our CFO, updated the Finance Committee on a recent report from Moody's Investment Services on their outlook for the not-for-profit and public health care. Moody's revised their outlook to negative based on their projections for the industry. Bill provided information on the factors in Moody's projections that led them to revise their outlook: operating cash flow contraction, low reimbursement rates, expense pressures, and continued uncertainty on the federal policy. And this concludes my report, Mr. Chairman.
Okay, very good. Thank you, Jim. Next on the agenda is the President's report. David Verinder, our CEO and President.
Thank you, Mr. Chairman. I'll start today, like I always do, with our organizational report card for fiscal year to date, 2018 through February. If we look in our service pillar, we start with our HCAHPS domain. We have a goal of on HCAHPS of being 8 out of 11, 8 at the 50th percentile or greater on the indicators. I'm happy to report that we are hitting that. We're at 8 out of 11. We'll show you in a couple of slides the detail on that. On the outpatient side, we have a goal of being 55 out of 58 of those domains being at the greater than or equal to 50th percentile. Happy to report that we're at 56 out of 58. On the people pillar, we have a goal of having our turnover of our part-time and full-time staff being the turnover ratio being less than 25% of those that are hired within the last 12 months. It's an indicator that we've struggled with. I'm happy to report we are under 25% right now at 24.95. We hope to maintain that or do better going forward, but I do think that our teams are having a positive impact on that. In the quality pillar, we have our infection prevention, which is our combined overall standardized infection rate. We set a pretty aggressive goal being 0.95 or lower, where the national average or expected number is 1.0. I will tell you we're doing incredible there. We're hitting 0.78. Really a lot of the work that our quality department and physicians and nurses are doing each and every day to keep that number very low. In the finance pillar, you heard our finances presented by Bill Wojcik, our CFO. We have a goal of being our budget of operating margin at 5.4%. We are projecting to exceed that right now at 6.7%. And in the growth pillar, we have two goals. The first being our inpatient admissions and observation patients. We have a goal being 43,429 or higher. We are exceeding that, projecting to exceed that at 44,983. And on outpatient registrations, we have a goal of being at 789,301 or higher, and we are projecting to exceed that as well at 813,230. We look at the details of our HCAHPS reports. You can see the 11 domains there, and that we are hitting. The green obviously show that we're hitting the goal of being at the 50 percentile or higher. The red are ones that we're a little bit low on, and you can see what those are: responsiveness of hospital staff, cleanliness of the hospital environment, and quietness of the hospital environment. Certainly, it's a very busy time in this hospital right now, and it is challenging to meet everyone's needs. But I got to tell you, I think our staff is doing a great job being able to maintain really some of the highest scores in the nation around this. So thanks to them. In the service category, we're talking about reaching out to our community. Sarasota Memorial cancer nurses Christy Stetson and Katina Wilcox provided information about cancer screening and cancer prevention at the February 24th Northport Community Health and Wellness Fair. It was also a full house last month at Sarasota Memorial Healthcare Center on Clark Road for the one-day Experience Ornish event, which offered a peek into the 9-week lifestyle program that's proven to reverse or undo heart disease. So we appreciate everyone coming out for those. In the quality category, Sarasota Memorial is just one of 3 cardiac programs in the U.S. and Canada that earned the highest 3-star rating from the Society of Thoracic Surgeons for patient care and outcomes in all 5 adult cardiac surgery procedures measured by the organization. The ratings place SMH's cardiac surgery team among the top performers of more than 1,000 cardiothoracic surgeons and cardiac surgery programs voluntarily submitting records to the STS database for analysis and comparison. So you see a picture there. You see Dr. Kelly, Dr. John Fong, Dr. Paul Vesco, Dr. Sell, and Dr. Hoffberger. And newest to that team is Dr. Paul Chomiak, who came after the picture was taken. But we really thank this team for getting us where we need to be and really leading the nation. Staying in quality, the Herald Tribune Media Group readers voted Sarasota Memorial's Venice Urgent Care Center as the #1 Reader's Choice walk-in clinic. So kudos to our entire team for earning that honor, and appreciate Jen Storch's leadership there. In people, on February 21st, patients, families, and staff of Sarasota Memorial's new rehab pavilion enjoyed a wonderful performance by 4 Perriman Music Program alumni, the latest in a series of musical offerings at the hospital by musicians throughout the community. And it really is moving. When we have these, we've done them in the courtyard and in various waiting rooms, and I think patients really enjoy the opportunity to come out and hear this. In the people category, Dr. Wong has been named SMH's new medical director for rehabilitation services. She is board certified in physical medicine and rehabilitation and brain injury medicine. Dr. Wong has spent the past decade specializing in neurorehabilitation for stroke, traumatic brain injury, trauma, and neurological disorders. Dr. Wong's practice is part of the Sarasota Memorial's First Physician Group network. So welcome to our organization. Staying in the growth area, we have our construction of the West Garage is well underway. The new structure will add 583 parking spaces to the main campus. Construction is scheduled to be completed by December 2018, and Lori assured me this morning it would be. Right, Lori? All right. We need to say a special thanks for 350 employees that work here who have volunteered to park off campus and be shuttled in each day to and from work to allow our patients and visitors and their families a place to park on this campus. So thank you to all 350 of you who've done that. We hope to give you parking places back next December. Staying in growth, our urgent care hours are extended to meet demand. Last month we experimented in the fact that we opened up university early at 7 a.m. and closed until 10 p.m. on Mondays. We are now, for the month of March, open up all 7 days for those extended hours. Once we're done with March, we'll kind of take a step back and see what we want to do afterwards. And if we want to continue to do that, we'll just look at the utilization and we'll evaluate all this for next year, next season, whether we need to do more with our other urgent cares as well. So more to come on that. We have free lecture series this month focusing on rehabilitation. You can see the dates are in front of you, but just in case you can't read that print, we do have it on our website, and I welcome everyone to go to our website on a regular basis. Take a look at what's upcoming lectures that are always free. Sometimes we ask for an RSVP just so we can make sure we get the right head count and get the right facility for it. But I would welcome everyone to come to that. And Mr. Chairman, that's my report.
Okay, very good. Any questions for David? All right, thank you.
Okay, thanks.
Next on the agenda is consent agenda. No items there? Okay. Public comments, Karen?
None.
Okay, thank you. Legal matters? Back to you.
No report?
Okay, thank you. Any other business? So
Mr.
very, yes.
Mr. Chairman, I move we adjourn.
Very good. We are adjourned.